So moving on to the adrenal gland, we'll go over, basic overview of the adrenal gland, and then we're covering two disorders of the adrenal cortex, Addison's and Cushing's, and then one disorder of the adrenal medulla, pheochromocytoma. I will briefly mention a third disorder of the cortex, hyperaldosteronism. So just a reminder of the location of the adrenal gland. Sits right on top of each kidney. The outer part, the cortex, and the inner part of the adrenal gland, the medulla. Also notice how highly vascular this area is. So that's going to be one of our big concerns when we talk about the third surgery in adrenalectomy, is risk of hemorrhage. The kidneys are highly vascular area. So the adrenal medulla contains those catecholamines, the epinephrine, norepinephrine, dopamine. They're neurotransmitters, part of that sympathetic nervous system activation, that fight or flight response. So they're responsible for a lot of symptoms that the patient is going to be experiencing if they have a disorder involving the adrenal medulla. So you can imagine if you had a hyper secretion of catecholamines, how you might have a very rapid pulse. You might feel pretty severe anxiety. All of those symptoms would be really magnified. So really understanding the functions of the hormones, again, I keep going back to that, is going to help you with all of these different disorders. So the adrenal cortex contains the glucocorticoids, mineral corticoids, and androgens. If you hear the term corticosteroids, that's really including glucocorticoids and mineral corticoids. So first let's just talk about our glucocorticoid, cortisol. Cortisol regulates blood glucose concentration by stimulating glucose formation in the liver. It decreases that inflammatory response by stabilizing cellular membranes. It prevents increased capillary permeability, so major role on glucose and decreasing that inflammatory response. Mineral corticoids, aldosterone, super important to have a solid understanding of as well. Aldosterone maintains extracellular fluid. It acts on the renal tubules to promote sodium reabsorption and water reabsorption and potassium excretion. So that's important to know how it normally functions. That way when we talk about a disorder where there's, let's say, increased secretion of mineral corticoids, we can kind of walk through how that patient might look. And the androgens, testosterone in men and estrogen in women. So the cortex, just think your sugar, salt, and sex hormones. In general, we are going to be looking at blood and urine levels of hormones. So, for example, 24-hour urine for cortisol or a serum cortisol level. Because there's not a steady, constant rate of secretion, with the adrenal gland, you're going to see a lot of stimulation tests and suppression tests to really evaluate the function of the adrenal gland. You really don't get great information by just a blood sample of a hormone level with the adrenal gland. So when we talk about the few different disorders that we're going to cover, we'll talk about which one you would do for which disorder. So Addison's disease is a decreased amount of adrenal cortex hormones. So sometimes it helps to remember that you have decreased amount of hormones, and the part of the treatment is going to be to add the hormones back in with Addison's disease. So there are different types of Addison's disease. Again, primary would be involving the actual adrenal gland, so the gland that the disorder is involving. So that is really the most common. It's responsible for 80% of cases, and it's actually an autoimmune destruction of the adrenal gland, and it results in loss of glucocorticoids, mineralocorticoids, and androgens, which is really necessary to maintain life. So that it can be very life-threatening. Patients often do not experience any symptoms until a significant portion of the adrenal gland is destroyed. Less common would be secondary. That would be a pituitary issue where the client is lacking ACTH, which is necessary to stimulate the adrenal cortex. It could be related to infection, tumor, variety of different reasons, or there could also be an issue with the hypothalamic pituitary axis because a client was taking exogenous steroids, so perhaps like a prednisone prescribed by a physician, and the patient abruptly stopped instead of tapering, and it could throw a patient into this Addison's disease. That's why patient teaching is so important for medication. And often the secondary causes a lack of glucocorticoids and androgens, but not usually the mineralocorticoids. So some clinical manifestations, which again, just remember, often it's very advanced before the patient experiences a lot of these symptoms. Nausea, weakness, weight loss, fatigue, orthostatic hypotension, salt craving, those are all very common. And a lot of the symptoms that we're talking about, they contribute to a lot of the electrolyte issues. That's going to be a part of our treatment. Again, I try to keep highlighting some clinical manifestations that should jump out at you for a certain disorder, and that hyperpigmentation, especially over joints, is really classic with Addison's disease. The emergency form of Addison's is Addisonian crisis, and it's usually, once the adrenal cortex has been almost completely destroyed or comes on suddenly due to a sudden decrease in hormones, like I mentioned, possibly abruptly stopping hormone replacement. It is an emergency critical situation. Patients are extremely hypotensive, extremely dehydrated. So again, we're going to be seeing those changes in the vital signs with the hypotension, the tachycardia. Electrolyte imbalances are a major concern, which can be life-threatening. So hyponatremia, again, they're having nausea, vomiting, diarrhea, they're losing a lot of their electrolytes. Increased potassium, that's really due to the effects of aldosterone. These clients have had a sudden decrease in aldosterone, and normally the function of aldosterone would be potassium excretion, and that's no longer happening. So patients are at risk for hyperkalemia, which is, again, can cause dysrhythmias, can be life-threatening cardiac complications, and patients are at risk for hypoglycemia, hyperglycemia due to that decreased amount of cortisol, and cortisol again has that major role in glucose metabolism. So really the focus of treatment is to prevent shock. So you're going to be replacing fluids, monitoring electrolytes, cardiac monitor. You'll be giving, high doses of IV fluids and replacing the steroids. So diagnostics for Addison's, this is where we're looking at a stimulation test. So I actually do this test all the time where I currently work in the infusion center. But patients come first thing in the morning because normally, remember, you have increased cortisol levels in the morning, so timing of the day a lot of times is important with these tests. So we draw a baseline level of cortisol and ACTH. We administer an IV push dose of a synthetic ACTH, so cosentropin, and then in 30 minutes and 60 minutes, we draw another cortisol level. If the client has a functioning adrenal gland, you're going to see the cortisol levels increase due to this synthetic ACTH that's stimulating the adrenal gland. If they have a disorder involving their adrenal cortex, then you're not going to see that response. So that's one way to evaluate adrenal function. There's also CRH, so talking about the hypothalamus stimulation tests, which I'm not going to go into detail, but again, remember there could be problems at different levels. So the hypothalamus, the anterior pituitary, or the adrenal gland. You would also be looking at electrolytes, EKG, radiology of the adrenal cortex or the pituitary, whatever the workup is pointing towards. So definitely potassium, sodium, glucose. Clients may have an increased BUN due to decreased blood flow to the kidneys. EKG changes with that hyperkalemia. So care of a client with Addison's disease, you're really going to want to, again, identify that underlying cause, because we talked about infection, medication, or the most common, the autoimmune response. And then you have to add back the hormones with Addison's disease. And this is lifelong therapy. Clients need to replace that glucocorticoid, that mineral corticoid, and possibly androgen replacement. So for the glucocorticoid, that's going to be hydrocortisone. And what do you think about the dosing of that? Should there any specific thoughts about how to take that, if there should be a higher dose in the morning or in the evening, or just once a day dosing? I would encourage you to think about the normal release of cortisol and that increased spike in the morning. So we're going to teach our clients to take 2/3 in the morning and 1/3 in the evening of that glucocorticoid response or replacement. The mineral corticoid replacement, fludrocortisone, that's going to be once a day in the morning. And these patients can actually have increased salt in their diet. They can be encouraged to add salt. It's not as much an issue going out to restaurants. That's actually encouraged. They need increased salt. They are chronically having that salt craving and that hyponatremia. Again, if that client is in the acute Addisonian crisis, they're having profuse nausea, possibly vomiting, diarrhea, you're going to be replacing large amounts of normal saline. probably alternating with a dextrose solution because they're also experiencing hypoglycemia. So you're monitoring their blood glucose, their electrolytes. They should be on cardiac monitor. We're very concerned about hyperkalemia, their neurologic status. You want to minimize any stressors, strict INO, and then you are replacing an IV glucocorticoid. So you always want to be watching for symptoms in case the dose is incorrect and the patient is receiving too high of a dose. So you'll be looking for signs of Cushing's, which we'll talk about. It's important that patients wear a medical ID bracelet. Again, we talked about daily replacement and that these hormones are necessary to maintain life. So an abrupt, if a patient missed doses, that could really send them into an Addisonian crisis. So that's important. You should teach your client symptoms of Addison's and Cushing's so that they can communicate with their provider, because again, there could always be an incorrect dose for the hormone replacement. They also need to be taught how to use an emergency kit, and that would be an IM injection of that glucocorticoid, because that needs, these patients absolutely need daily replacement when they have Addison's disease. So that IM hydrocortisone would be important, and including a family member, a neighbor, whoever, because a lot of times if, it may be, they may not be able to self-inject, but let's say they have a gastroenteritis, they're really going to need to replace that hormone even if they can't keep it down orally. Also, times of stress, clients need to increase their glucocorticoid replacement. Just like if you or I were scheduled for a surgery, or we're experiencing an illness, or under stress with anything, any sort of stressor, your body would normally compensate and have an increased production of cortisol. Because your adrenal cortex is no longer functioning, that's not possible, and you have to increase your amounts of your hydrocortisone replacement, and the patient would have very specific written instructions from their physician what to do. It's important that they inform all of their healthcare providers, so their dentist, they're going to have a surgery, anything. So the past two slides, I already included that information. I got a little ahead of myself on the other slide, so I didn't repeat that. Moving on to corticosteroid therapy patient teaching. There's just a couple slides here, and very important, definitely something that you want to know for the exam, for the final. I know the first half of 104, Justin also covers some corticosteroid therapy with some of the different neurological disorders, especially that you cover. So some of this will be a review, and just kind of think to yourself some cases where somebody might need corticosteroid therapy. I'm sure many of you have been administering steroids in clinical, so perhaps doing a methylprednisolone IV push, administering oral prednisone, hydrocortisone, Solucortef. So we just went over the functions of glucocorticoids. Cortisol, major role on decreasing inflammation, suppresses the immune system, plays a major role in blood pressure regulation with the effects of mineral corticoids. So again, the corticosteroids include the glucocorticoids and the mineral corticoids. So a lot of the side effects are going to be related to the actual functions of cortisol and aldosterone. And again, you're always weighing the risks and the benefits. So there are many, many side effects of corticosteroid therapy. I don't want to read through each of these. I'm going to kind of address them on the next slide when we cover patient teaching, because patient teaching, how we teach the patient to take the medication and protect themselves, is really addressing all of these side effects to help minimize the side effects. But do take a look at this. There's also a table in your textbook, 49.22, that goes over all of the side effects. So patient teaching is super important for corticosteroid therapy. This is definitely something that you want to really know because these drugs are so common for so many different disorders. Earlier I asked you to try to think of some different diseases or disorders where clients might use a corticosteroid, and hopefully you were able to come up with several. There's numerous conditions. So just throw out some examples. Lupus, Addison's disease, head trauma, increased intracranial pressure, inflammatory bowel disease, asthma, an allergic reaction, nephrotic syndrome, any sort of organ transplant. A lot of times clients are on corticosteroid therapy to help suppress their immune system to prevent a rejection. And there's many, many, many more. Perhaps MS flare you talked about with Justin. So moving on to patient teaching, diet is super important. We want to teach our patients to increase calcium in their diet, eat protein, calcium with vitamin D, protein, potassium-rich foods. They typically do not restrict sodium unless the client is experiencing edema, but you certainly wouldn't want them to have, increased amounts of sodium because of the mineral corticoid property. So again, for diet, increase calcium, potassium, protein-rich foods. Exercise is really important. The corticosteroids cause changes and weakening to the bones, so clients are at risk for osteoporosis and fractures. The client that's been on long-term steroid use may barely injure themselves at all and suffer a pretty significant injury. So weight-bearing exercise, super important for patient teaching on long-term corticosteroids. This does cause hyperglycemia, so that's a big problem, especially with our diabetics that already have increased glucose, delayed healing, increased risk for infection. Now they're on a corticosteroid with that side effect that can really cause problems. So a lot of times a diabetic may need increased insulin, or perhaps they were not on insulin and they might need insulin for this period of time that they're on steroids. So glucose is a big thing to remember. There is a risk of peptic ulcer disease, so we want to teach our patients to take oral steroids with food, to notify their provider if they're having any abdominal pain, nausea, vomiting. That would all be important. Meticulous hand washing, vaccines, avoiding individuals with any illness would be important because, again, the immune system is suppressed and patients are at risk for infection. You want to inform all healthcare providers, so I mentioned like the dentist, but also the ophthalmologist. There's an increased risk for cataracts and glaucoma for somebody that's on long-term corticosteroid therapy. And then we talked about the weight-bearing exercise and the calcium with vitamin D to help reduce osteoporosis. So all of those are important patient teaching pieces. Okay, so we're going to spend most of our time on Cushing's syndrome, and we will touch on hyperaldosteronism, which is very straightforward. So Cushing's syndrome is caused by excess corticosteroids, which again was really talking about your glucocorticoids and your mineral corticoids. There's many different causes with Cushing's. So I would encourage you to just take out a blank piece of paper and just start drawing. Draw the hypothalamus with CRH, the anterior pituitary with ACTH, the adrenal cortex with cortisol, aldosterone, androgens, and start drawing arrows because the hypothalamus stimulates the anterior pituitary to release ACTH, which then travels to the adrenal cortex to stimulate the release of your corticosteroids and your androgens. So there's several different areas where there could be a problem. So sometimes just drawing can really help. So let's just go over the different causes. One cause could be a client taking prescribed steroids. So iatrogenic administration of exogenous corticosteroids, a physician prescribing systemic steroid therapy. And those patients would be at risk for developing Cushing's, and they should be screened regularly and on the lowest dose for the shortest period of time possible. There could be a pituitary adenoma that's stimulating an over-secretion of ACTH, which is traveling to the adrenal cortex and constantly stimulating that adrenal cortex. It could be an actual tumor within the adrenal gland that's causing that hypersecretion. Or it could be an ectopic tumor, so perhaps a pancreatic tumor that is independently secreting ACTH and stimulating that adrenal cortex. So when I think of symptoms for Cushing's syndrome, I think of a lot of symptoms that affect the entire body, definitely a lot of body image, but some serious complications. And we'll talk about electrolyte changes with your vital signs, obesity, things like that. This picture is showing the moon face and that plethora. I don't know if you can see on your screen, but the thinning of the skin and also the thinning and fragile capillaries and just that little bit of redness underneath the skin there. But that's pretty characteristic with Cushing's, that moon face. This is right out of your textbook, and it really covers the classic symptoms with Cushing's. So if this is something that you can just kind of file away, it'll help you with a lot of the symptoms, organizing symptoms in your mind. But we talked about the moon face, also that buffalo hump, that increased fat tissue in the upper back. You'll notice the thin extremities, but that central obesity. Purple striae or stretch marks, increased thinning of the skin, so injuries are easy, increased ecchymosis. Clients with wounds tend to have a delayed healing. At risk for acne, possibly related to androgens. You can see the central obesity, the purple striae, the ecchymosis. So with that excess glucocorticoid, we're really concerned about hyperglycemia, which I mentioned, that cortisol causing increased gluconeogenesis. Clients suffer from muscle wasting and do experience weakness. So that importance of weight-bearing exercise, including protein in the diet, at risk for osteoporosis, which we talked about, and that importance of weight-bearing exercise, preventing injury. I don't know if you've cared for any clients perhaps in clinical, maybe that suffered from advanced COPD and they were O2 dependent and steroid dependent at home, and maybe they were hospitalized for a flare-up. A lot of times you can really see lots of areas of ecchymosis, really super thin skin where you're terrified to take a Band-Aid or a piece of tape off their arm for fear of developing a skin tear. But their skin is, has that loss of collagen and is really at risk for injury. And then it takes a while to heal. They have delayed wound healing, increased risk for infection. So we talked about the glucocorticoid effect. The mineralocorticoids do cause hypertension, which makes sense if we know that aldosterone causes water and sodium retention and potassium excretion, and now they have excess aldosterone. They're going to be experiencing hypertension and also hypokalemia, which can be just as serious as hyperkalemia and place the patient at risk for a dysrhythmia, which can be fatal. And the adrenal androgen excess, if it occurs, may be responsible for the acne symptoms that we talked about, the gynecomastia, the overgrowth of breast tissue in male, the hirsutism, the increased male pattern of hair growth in women. So that can all be related to that. This is a video that reviews some of the same information that we just kind of went over, but also is a personal story of a patient. I usually only show 5 minutes of this in class, the first 5 minutes. This client had a pituitary adenoma, and you actually see her post-op for a transsphenoidal hypophysectomy. So you get to see like the nasal trumpet, the nasal packing, and just her share her experience with her journey to diagnosis and a lot of the symptoms she was experiencing. So if you want to take a look at that, I would only watch like the first 5 minutes or so. So for diagnostics, you may see plasma or saliva cortisol levels that are increased. This may be a case where you see a suppression test. So with Cushing's, a client would have an IV or would have a replacement of steroid, so a dexamethasone in the evening, and then they would have early morning blood draws of cortisol. And somebody with a normal functioning adrenal gland, they really shouldn't see increased cortisol levels because they had a steroid on board. But somebody with Cushing's, you're going to see that elevated cortisol level despite having steroid administered. A 24-hour urine cortisol level can really give you accurate information on persistent increased glucocorticoids. ACTH levels can also help you differentiate the cause, because the cause is going to drive the treatment. So if you think back to that first slide, there was like 4 different causes for Cushing's. So in order to be able to treat it and help the patient, you really have to identify the cause. So this can help you kind of differentiate that. So the whole goal is to bring down the corticosteroid levels. So depending on the cause, it might be a transsphenoidal hypophysectomy, removing that pituitary adenoma that's causing issues with ACTH. It could be removing that adrenal tumor with an adrenalectomy. What would be the #1 post-op concern? hopefully everyone's saying hemorrhage because we talked about how highly vascular that area would be, but also blood pressure and pulse fluctuations because it's of the effects of the adrenal medulla. If it was an ectopic tumor, so a lung tumor, a pancreatic tumor that is independently secreting ACTH, it would be treatment focused on that, whether it was surgical removal, chemotherapy, radiation, whatever the treatment may be. So what would the treatment be if it was a client on exogenous steroids? Absolutely, you're reading it on the slide here. You would hopefully be able to taper the client off of the steroid if they were truly developing symptoms of Cushing's. Sometimes that's not possible. Maybe it's a client that had a kidney transplant, and in order to help prevent their body from rejecting their transplanted organ, they have to be on corticosteroid therapy. Or perhaps it's a client, like I mentioned, with advanced COPD that's O2 dependent, at rest is short of breath, and needs that daily steroids just to be able to function. So it really sometimes can be tricky to discontinue long-term corticosteroid therapy. So if that's the case, they will look at, slightly decreasing the dose, maybe going to every other day dosing. So moving to the nursing process, assessment, again, you want to really do that thorough health history because that's going to help give you information about the cause of Cushing's. And a thorough home med list, so are you on a steroid, the dose, how long, any symptoms they're experiencing. So really asking those key questions, thinking about Cushing's. And then your physical exam, looking for those clinical manifestations, the changes in the vital signs, the body changes, weight, all those clinical manifestations that we talked about. So you're going to be looking at electrolytes. We talked about hypokalemia, the hyperglycemia. Clients may have dyslipidemia due to that increased cortisol and increased persistent hyperglycemia. Changes to their white blood cells. Increased corticosteroids cause early release of immature white blood cells from the bone marrow. So again, affecting and placing them at risk for infection. So you may see increased white blood cells. There's many nursing diagnoses that would be appropriate for these clients that have Cushing's. It's important to identify high-risk clients. So a lot of the patients' examples that I shared with you, but taking steroids, that's really the big one. And again, there's so many conditions where patients need long-term corticosteroid therapy. But teaching the patient how to take their steroids and minimize side effects is helpful for those clients. So I feel like I've repeatedly talked about vital signs, weight, glucose, the increased risk for infection. Patients are also at a higher risk for blood clots, so due to the increased clotting factors, so VTE prophylaxis would be important. I think that slide out of your textbook that has all the symptoms on the client, you could really, like, body image really jumps out. So it can really affect, clients' feeling depressed and having body image concerns, once the client does get treatment for Cushing's syndrome, a lot of those body image concerns will improve. So that is hopeful and something that you could communicate to your patient. So pre-op care, you want clients to have good control of their blood glucose, their blood pressure, and have their electrolytes corrected. Good nutrition is important for faster recovery. So post-op adrenalectomy, we've mentioned it twice now. Patients are at a high risk for hemorrhage. With the manipulation of the adrenal gland, there's a possible large release of hormones into circulation, so that can affect blood pressure, fluid balance, electrolytes. So you are really going to have to be closely monitoring your client. They really would be in a critical care setting post-operatively. They will need immediate IV corticosteroid replacement at higher doses, because remember, anytime your body is under stress, and surgery would be a stressor, you would normally have an increased release of corticosteroids. You'd still be monitoring cortisol levels. Infection prevention, maintaining wound healing, and monitoring for signs of adrenal insufficiency would be important post-op adrenalectomy. These clients should also wear a medic alert bracelet. Try to avoid stressors. If a client has a bilateral adrenalectomy, they will need lifelong replacement therapy. They will need to have the teaching that we talked about with the dosing for the replacement of with hydrocortisone, the aldosterone replacement, and during times of stress, increase their doses. It would be lifelong. They'd have the same emergency kit, injection, teaching, and that would be for a bilateral adrenalectomy. So the last disorder involving the adrenal cortex is hyperaldosteronism. It's excess mineral corticoid. So again, if you really have the functions of aldosterone down, you can totally think through what's going to be happening with this and the symptoms that the patient will be experiencing. So it does cause sodium retention and potassium excretion. I'm going to let you read through the difference between primary and secondary. All the information is here on the slide. So hypernatremia, hypertension, hypokalemia is what we're concerned about. So you will see increased aldosterone levels, sodium levels, the decreased potassium. Radiology may be indicated to visualize the adrenal gland. Treatment would be adrenalectomy to remove the adenoma. We talked about adrenalectomy pre and post-op care. So the main concern is really fluid electrolyte, blood pressure control, preventing cardiac complications due to potassium-related dysrhythmias. So the last endocrine disorder that we are going to talk about before starting diabetes is a disorder involving the adrenal medulla. There's only one involving the medulla. It is a tumor that causes an excess production of catecholamines. So you can only imagine how life-threatening this disorder could be. It is pretty rare, but if you choose to work in an urgent care or an ER, anytime anyone walks through the door, extremely hypertensive, thinking that they're dying, having a heart attack, and they have a cardiac workup and it doesn't really show anything, always kind of keep this in the back of your mind. Diagnostics would be a 24-hour urine for catecholamines, and then a CAT scan or MRI to identify the tumor within the adrenal medulla. When your client is doing the 24-hour urine for catecholamines, you do want to do patient teaching to avoid any caffeine, chocolate. Try to avoid any palpation because you can further cause release of catecholamines with your physical assessment. Clinical manifestations. So again, like I mentioned, severe hypertension, tachycardia, headache, profuse sweating. So you can imagine why the client feels like they're dying and they're having a heart attack. It usually comes in attacks. So it's usually in an older female. So a lot of times clients think that if they don't think they're having a heart attack, they think maybe they're starting to go through menopause because they kind of have like an attack where they're extremely sweaty, flushed, not feeling well, and then it kind of subsides, and this can happen for a period of time. So just one more comment about the previous slide. We talked about the hypertension, the headache, the sweating, the tachycardia. What do you think their glucose would look like? Epinephrine is one of the catecholamines, and epinephrine actually opposes the effects of insulin. So it actually really causes hyperglycemia. So these patients would also have hyperglycemia due to that excess production of epinephrine. The treatment would be adrenalectomy, and you'd really want to do tight control again for glucose, electrolytes, blood pressure, pre and post-op. And these patients really need frequent follow-up. So please, again, I hope that you were jotting down questions as you were going through these PowerPoints, because we will have a collaborate session on Blackboard, and I'm always available by email, and we can also have a discussion board on Blackboard.